Well, welcome to today's ICMDA webinar. This is the second in our series of webinars, which is specifically dealing with issues around COVID-19 and a Christian response to that. My name is Peter Saunders. I'm the Chief Executive of ICMDA, the International Christian Medical and Dental Association, which brings together 84 national movements of doctors and dentists around the world. And our aim is to start and strengthen national associations of Christian doctors and dentists. Today's seminar is on the subject of Christian ethics, compassion, and COVID-19. And we're very privileged to have Professor John Wyatt joining us for that. The way this will work is that John will give a presentation of about half an hour, and then we will open it up for questions after that. So if you see on your screen, there's a Q&A button at the bottom, and you can put in your questions to that during the time that John is speaking, and then we will field them at the end. And you will have the chance to vote questions up or down depending on how important you think that they are. The whole session is recorded and will be available on our YouTube site and via our website afterwards, so that you'll be able to encourage others to come and listen to it too. But to our guest, John Wyatt is Emeritus Professor of Neonatal Paediatrics at the University College of London, and also a Senior Researcher at the Faraday Institute, Cambridge, and the President of the UK Christian Medical Fellowship, which is a member of ICMDA. He's got a clinical background as a paediatrician, caring for sick and premature infants, and also a medical scientist researching into the prevention of brain injury in newborn babies. He's always been interested in ethical dilemmas raised by advances in medical technology, and has frequently engaged in public and professional consultations and debates from the perspective of the Christian faith. His book, Matters of Life and Death, Human Dilemmas in the Light of the Christian Faith, has been translated into more than 10 languages, and his most recent book, Dying Well, published by IVP, is now available too, and he's contributed a chapter to a new book, Healthy Faith in the Coronavirus Crisis, due to be published by IVP this month. John and his wife Celia are long-standing members of All Souls Church in London. So welcome, John.
Thanks very much.
Over to you.
Good to be here.
Thank you very much.
Great. Well, thank you so much. It's a real privilege to be taking part in this extraordinary gathering at an extraordinary time. And I'm just struck at God's sovereignty. I bring my greetings from London, which is at the moment one of the epicenters of the pandemic, and we've had a tragically high number of deaths. But of course, this is a global phenomenon, and all of us, I think, are struggling to try to understand what's going on and try and work out how we respond, particularly those of us who are Christians and people of faith. And I think from a Christian perspective, the first thing we have to do is recognize the sovereignty of God, to recognize that God is in control. Certainly for so many modern people, and I think often for medics as well, we get the impression that we are in control of the situation, that our technology, our education, our abilities, we're able to control and make a better world. And what times of plague like this remind us is that we're not in control. And of course, we look at our leaders and we realize they're not in control either. And nobody really knows what is happening. Nobody knows what the future is going to mean. And so I do think right at the beginning, we need to remind ourselves from a Christian perspective that there is someone who is in control. There is someone who, in the Bible, it was often the sea was regarded as the ultimate chaos of force by the biblical writers. And yet the God of the Bible says to the waves, this is how far you can come and no further. And not only that, not only is God in control, but what the scriptures teach us is that if we are part of the Christian family, if we are people of faith, then we are God's workmanship. This is Paul writing in Ephesians, and the literal Greek is poema. We are God's poem, created in Christ Jesus. Why? To do good works which God prepared in advance for us to do. And so, extraordinarily, what the Bible teaches us is that actually, at this time of pandemic, God is creating good works for us to do, and He's prepared. This is all part of the plan. It's all part of the story. It's all part of the narrative. And you know, global pandemics have been going on since the history of the dawn of time, and the last very major global pandemic was in 1918, 1919, the great influenza pandemic. And perhaps the question to ask ourselves is not why we're facing a pandemic now, but why did God delay this global pandemic until this point? And of course, I don't know, nobody knows God's sovereign purposes in all this, but I just wonder whether part of the reason is that God delayed the next pandemic until this kind of technology had got to such a peak of sophistication that we can do what we're doing now, that actually we can communicate across the world, we can share ideas, we can support one another, we can pray for one another, and as a global family. And so isn't it remarkable that this may be part of the plot? God knew that we were going to meet like this today. And I just want to say what a privilege it is for me to be able to share with sisters and brothers around the world. So fundamental to the idea of Christian ethics is the idea that we're called to be wise stewards. God has given all of us, including those of us in the healthcare professions, an abundance of resources, but we're called to act as wise stewards of the resources we've been given. Now, you may be working in a very high-tech, well-resourced country. You may be working in a very low-resourced country. You may feel that the resources that you have available to you are very limited, and yet the basic truth is that God does give us all kinds of resources, not just specific healthcare resources, but all the resources of an intellect, the resources of a Christian family, the resources of teaching and backgrounds and all these other things. So how do we act as wise stewards of the resources that we've been given? And, you know, a central example of this is in the very well-known parable of the talents in Matthew chapter 25. And I'm not going to talk in any great detail about it, but just briefly, if we think of that parable of the talents, what we learn is, first of all, we don't own the resources that we're responsible for. In this parable that Jesus told, he talked about a rich man who called his stewards, his servants, to him and gave them the resources, but he gave them the resources on trust. So we don't own the resources that we're responsible for, but we have them on trust. Second, we're answerable to God for how we use the resources that are being given. And third, we therefore need to employ our resources carefully, with wisdom, and before the face of God. But ultimately, we're answerable to God, and therefore we need to be wise about how we use the resources available to us. But we shouldn't feel too burdened. I think it is possible, particularly for health professionals confronted in a time of health emergency, to feel a terrible burden of responsibility. How on earth do we cope with what could be overwhelming needs and complete systems which could be completely overwhelmed? And so I think we also need to remind ourselves of the Christian principle that Jesus said, "Come to me all who labor and are heavy laden, and I will give you rest. Take my yoke upon you, learn from me, for I am gentle and lowly in heart, and you will find rest for your souls. For my yoke is easy, my burden is light." So we mustn't allow ourselves to become unduly burdened and distressed by the responsibilities we carry. I can certainly remember sometimes, I worked for more than 25 years in an intensive care unit in central London, wrestling with some terrible and overwhelming clinical problems. And at times I did feel completely burdened by the pressure of clinical decision-making, by the terribly distressing things that I was witnessing. And I need to remind myself repeatedly that we're only called to do our best. We have limited resources, we have imperfect knowledge, but we're called to do our best with what we have. So an important concept which is being talked about a lot is the concept of triage. And the word comes from the French, trier, which means literally to separate, divide, or select. And the word was used in its medical meaning, really it started with military medicine in the late 19th, early 20th century, as an idea of separating severely wounded patients on the battlefield into those who would be treated and those who wouldn't. But in principle, it seems to me triage in a time of health emergency represents good stewardship. There's nothing fundamentally wrong with the concept of triage, the idea that we need to select patients for treatment, but it must be carried out according to godly Christian ethical principles. And that's really what we want to focus on for some of the rest of this presentation. So what are some of those godly Christian principles? Well, surely we have to start with the fact that every human being is uniquely precious. They're made in God's image. They're known and loved by Him. And each unique human being has an eternal significance and destiny. So we have to start with the fact that all of our patients, all the people we're confronted with, are uniquely precious. And there is no such thing as a life that is not worth living. And, you know, at times of health emergency, it's possible for health workers, politicians, economists, just to conclude that some people's lives are worthless. But as Christians, we can never do that. Every human life is uniquely precious. But just because a particular medical treatment is available doesn't mean that we must use it. So Christians have always recognized that just because treatments are there, we don't necessarily have to use it in every case. So we have to be wise and selective about who we treat. And this means that inevitably there is a degree of healthcare rationing. There is never enough treatment available for absolutely everybody to be given absolutely every treatment. And what we have to recognize is that all treatments have potential benefits, but every treatment also carries burdens and potential risks. And so I think this is a very important principle of Christian ethical medical treatment. We have to, in every individual case, we have to balance the benefits that our treatment has to offer with the burdens and risks of that treatment. And this is particularly important if we're thinking about really invasive and potentially very damaging forms of medical treatment. So one of the huge dilemmas in well-resourced medical systems is we do have available to us extremely invasive methods of life support involving techniques such as intubation, mechanical ventilation, even ECMO, extracorporeal membrane oxygenation for those who are with kidney or liver failure or respiratory failure. And the questions is, how do we use these extremely invasive treatments? Because the truth is, to die on an intensive care unit after days or weeks of futile medical treatment is a terrible way to die. And that's something that we should be trying to avoid. If we can predict that a patient is highly likely to die in the intensive care unit, then we really have to ask ourselves, is that the right thing? Is it the right use of our technology? But is it the right thing for this patient? Certainly, we've been wrestling with this. We have a close family member who's in their 90s. And it's pretty clear that if she developed COVID-19 and was admitted to an intensive care unit, there's a very high chance that she would die in the intensive care unit. And so with her agreement and with the health professionals, we've made a statement that if she becomes unwell, we don't wish her to have invasive medical treatment, including admission to an intensive care unit. So we're called to balance the benefits and the burdens of any particular treatment. Now, that's not always easy, of course, because again, we have imperfect knowledge. Particularly, we don't know a great deal about COVID-19. We don't know what the implications of all other comorbidities are. But certainly, this is an issue that, nonetheless, the principles are we do this balancing in each individual case. And wise stewardship implies that we use our limited health resources for those who have the maximum likelihood of benefiting from it. So, to target our resources to those patients who have the best chance of having a good outcome, the best chance of surviving, responding to treatment, in principle, fits, I think, with Christian ethical principles. But it's important, therefore, that treatment decisions should be individualized for each patient. So I feel quite strongly, and I think most other Christians do, is that we should not be making blanket rules based, for example, on age or on gender or on levels of disability or on socioeconomic backgrounds or things like that. Instead, all our treatment decisions should be individualized. We should take each patient and assess each patient wherever possible. And secondly, we shouldn't be making treatment decisions just based on subjective factors, such as our hunch, our intuitions. Wherever possible, we should be trying to base our treatment decisions on objective information about the likelihood of benefit. So one of the interesting tools that is being used quite a lot in the UK at the moment is called the Clinical Frailty Scale. And this is being used to assist decisions about whether intensive care should be carried out in COVID-19 patients. And if you're interested in this, the website is there for explaining how the Clinical Frailty Scale works. It's intended particularly for older people, for people who are age 65 and over. So it may be less relevant in some other countries. But for countries which have a larger population of older patients, then it seems that something like this scale is quite helpful. The Clinical Frailty Scale, basically, you have quite a detailed assessment of people's chronic state. So you're asked to try and assess the degree of dependence of the patient 2 weeks prior to admission, before the acute insult or the acute infection. And the Clinical Frailty Scale goes from 1, those who are very fit, all the way through to 5, those who are mildly frail, 6, moderately frail, 7, severely frail, through to 9, terminally ill, approaching the end of life. And there is objective evidence showing that if you take the Clinical Frailty Scale, that's on the left-hand column, and these are data that were published before the COVID-19 epidemic, so it's not specific to COVID-19, but what they show is that there's quite a strong relationship between inpatient mortality, that means they will die in hospital, and also the risk of readmission. And that's in the higher grades, that means with the increasing levels of frailty. And so it's interesting that the official guidelines in the UK have suggested that clinical frailty scales should be used when we are considering intensive care in older patients. And they've suggested that a clinical frailty scale of more than 5 should mean that, in principle, patients should not be admitted into the intensive care unit. Now, so I don't particularly want to discuss the precise details of this, but I think it just indicates the kind of objective scales and measurements which can assist. Now, obviously, these are all tools. They don't make the decision. There has to be individual human judgment, there has to be clinical judgments, and there has to be discussion wherever possible with individuals and with their relatives. But using these kind of objective tools certainly helps. There are other publications which are coming out, and this was a letter recently in The Lancet, which suggested a COVID-19 triage strategy for low-income settings. And there's a flowchart here suggesting how patients who have been exposed to COVID-19 should be treated, and decisions made based on tachypnea, on whether or not to give oxygen, then a nasopharyngeal swab, and so on. So a simplified triage system like this, again, I think is very helpful in helping us to decide in relatively objective ways how to treat individual patients. But to come back to basic principles, we're not at liberty to decide as human beings whether another human being's life is worth living. If you like, that's above our pay grade. It's not something that we as human beings can do. I have no right to tell you whether your life is worth living. Only God himself knows about the ultimate value of a life. But we do, particularly as clinicians, have a responsibility to decide whether a treatment is worth giving. So we don't make quality of life decisions, but we do make quality of treatment decisions. We have to decide whether particular treatments are going to be valuable and worthwhile in an individual case. So what possible ethical strategies are there for triage during COVID-19 the COVID-19 health emergency? And in particular, how should we do if there's a risk? How should we act if there's a risk that our available resources are going to be overwhelmed? Well, as I've emphasized, I think the basic and most important strategy is that of trying to decide the likelihood of each individual patient benefiting from intensive treatment. If the patient is either relatively mild, so that they're unlikely to need intensive treatment, or so severely affected, or there are comorbidities, or they have a high level of clinical frailty, then it may be perfectly appropriate to decide that we won't use our intensive resources for that particular patient. Another strategy which can be used and which may be appropriate is just first come, first served. I mean, at one level, that seems very crude and very simplistic, but I think it is perfectly reasonable if we have a limited amount of resources to say that we will use those resources for the people who are most likely to benefit until the point at which those resources are used up. And then it simply isn't possible to treat anymore, and we must try and do what else we can for those other patients. What I feel quite strongly, however, is that we should resist the following suggestions that have been made for triage. So I don't think we should use any of these, either a blanket rule, as I've already said, based on age or gender or disability. Fourthly, I think we shouldn't use it has been suggested by some ethicists and even some politicians that we should try to assess the benefit to society of an individual patient. So, for instance, if there was health resources were overwhelmed, we should particularly prioritize health resources to patients who are health workers, or possibly to people who could pay for it, or possibly to politicians and so on. Just, in other words, trying to assess the benefit to society of an individual patient. I believe this is wrong and really doesn't align with Christian ethical principles, because God himself treats us all justly and fairly. He doesn't discriminate. Do you remember there's a verse which says that God causes his sun to rise on the just and the unjust? And in that sense, God gives his creation blessings indiscriminately. And we're called to act with justice. And it's not just to discriminate for people who have particular characteristics. And also in many health systems, including here in the UK, the NHS depends on a covenant between the public, who all pay for the NHS out of their taxation, out of general taxation, and NHS managers and workers. And the covenant is that we will give our services equally without discrimination. We will give it with justice and with fairness. if it became known that the NHS was targeting particularly healthcare workers for its resources, then that breaks that trust, that sense of justice. So I don't think we should be using our health resources or carrying out triage based on the clinical benefit. And finally, I don't think we should be using the utilitarian calculations, which are beloved by some bioethicists, where we do a great calculation, we work out the maximum benefit for the maximum number. And that means that we refuse to treat some people, we just make this mass calculation. Again, as I've said, I believe very much that we should be making our clinical decisions based on individual patients and not just on a mass calculation for the whole of society. And in this terrible epidemic, we need to ask ourselves, what does it mean to die well? Sadly, in this epidemic, particularly in Western countries, many patients are dying in one of these two ways. Either on the left is failed cardiopulmonary resuscitation, which is a terrible way to die. And there's lots of evidence now coming out that if a patient with ARDS because of COVID-19 goes on and arrests, it's extremely unlikely that CPR will be successful. And yet a lot of patients are dying with failed CPR. And a lot of patients are dying in an intensive care unit, sometimes after 2, 3, or even 4 weeks of treatment. And then they die at the end of that in anonymous antiseptic conditions without their loved ones. And I think this is a real tragedy. I think our responsibility as healthcare professionals is not just to try to use our resources as wisely as possible, but it's also to try to ensure that the patients who are not receiving active treatment are unable to die well as much as possible and to die with proper palliative care. And that means that there is a real argument, certainly in developed countries, that if elderly people who are frail or particularly vulnerable or with comorbidities develop COVID-19, it's actually better for them not to be admitted to secondary care, not to be admitted to hospital, but to try to receive palliative care in a home setting when they can have relatives and as well as expert palliative care provided. So if we decide to withhold or withdraw intensive or life support treatment, we don't stop caring. We never stop caring. We have a duty to provide as good palliative care as we can. So again, just to point to another resource, the Association for Palliative Medicine of Great Britain and Ireland has recently produced an excellent document called COVID-19 and Palliative End-of-Life Bereavement Care. And that's available at that website. And I recommend that. It's got a wealth of very helpful and detailed information. The whole question of personal protective equipment has created a lot of concern and political controversy and concern amongst health professionals. And it does raise this fundamental question: how do we balance our duty to care for the sickest patients with the need to protect ourselves from infection? And this seems to me like one of those deeply painful and difficult questions. Of course, if we allow ourselves to become infected without taking any kind of precautions, then as a health professional, we're no longer part of the solution and become part of the problem. And so I think there is a duty for us to try to minimize the risk of infection, but it isn't an absolute duty. It seems to me, and the history of plague is something which goes back for 2,000 years, that often Christians have been prepared to act self-sacrificially to show the love of Christ, to care for patients. They try to minimize their risk of infection, but they know that they can't reduce it completely, but that means they're still prepared to put their lives at risk in order to do their best for their patients. And I'm grateful to Peter Saunders for this story, this picture, which shows, it's taken from India, shows that the innovative use of a bin bag liner can be used to provide some form of PPE. So perhaps again, we just need to be really creative about seeing what resources are available and seeing how we can use those to develop the best way of protecting ourselves and our co-workers from infection. So as I come to the end, I just want to draw back and say that it's clear that we're never going to understand ultimately why God allows suffering. Suffering is a mystery, and why God has chosen this particular time, and why he's chosen us as health professionals to be in the middle of this health emergency. But you know, what we see time and time again is that God is able to redeem these terrible, evil, inexplicable situations and bring blessing and healing. And it's by faith, I believe, there's no evil situation, however twisted, however malevolent, however apparently meaningless and hopeless, which cannot in some sense be transformed by God's grace and power into blessing and healing. And so we need to be looking for ways, redemptive ways, that God is going to use this situation. How is he going to use it for us, to help us, to change us? How is he going to use it for colleagues? Is he going to use it to give us opportunities to share our Christian hope, to show the love and compassion of Jesus? Years ago, an Indian social worker was watching what Mother Teresa of Calcutta was doing with her wonderful caring work for the beggars on the streets of Calcutta. And he said, you know, we do it for something. We do our social work out of principles, out of ethical principles. But he said to Mother Teresa, you do it for someone. And that does seem to me that is a critical difference, isn't it? That as Christian health workers, our compassion, our work is there not just out of high ethical principles, but we do it for someone. We do it for the Lord Jesus and to be his hands in this extraordinary time. And we have to remind ourselves when we feel that actually our love is coming to an end, when it feels hopeless, when we feel depressed and despairing, we have to remind ourselves of the words of Paul in 1 Corinthians 13. He says, love always protects, always trusts, always hopes, always perseveres. Love never fails. How can he say that? Answer, because his eyes are fixed on the future. And he knows that however hard and stressful and difficult this situation is, everything that is done in genuine compassion, in genuine caring, is never wasted. It isn't lost. And in some strange way, it's going to become part of the new heaven and the new earth. And so I close with these words which I've used before. Hope is to hear the melody of the future. Even in the middle of this terrible pandemic, we need to try to hear that melody of the future. And faith is to dance to that melody in the present. May God bless you as you face these challenging situations. And may you see the grace of the Lord Jesus in the midst of it. Thanks.
Thank you very much, John, for an amazing presentation, incredibly comprehensive, and bringing together not just Christian and biblical principles, but also applying them practically to the situations that we all face. So, John, first of all, from Howard Lyons, the well-known UK journalist and author Max Hastings, he said, who's aged 74, has argued that any policy decisions by leaders about our response to COVID-19 should favour helping the young rather than the elderly, who in the West especially have already enjoyed a good life. What are your biblical reflections on that question? I won't ask how old you are, John.
Yeah, no, quite. No, I'm in my late 60s, so I definitely come into the category. It's really interesting, isn't it, that if you were to take some secular ethical principles, like if you take someone like Peter Singer and his position, you could easily argue that actually COVID-19 is doing us a great benefit. It's basically getting rid of all those old people who are economically unproductive, and basically it's allowing the younger people to survive. And so it's a great thing, isn't it? We should just let the virus run riot. But it's very interesting that actually I haven't heard those arguments at all, really. What I hear not just from Christians, but actually from everybody, at least in the UK, almost everybody, is that actually we have a duty to protect and care for everybody in our society. And that to just toss away the elderly is the absolute opposite of what Christian ethics is all about. Yes, of course, we don't specifically select the elderly, but basically what we do is we provide healthcare for the whole of the community. And it seems to me that is a very strong ethical principle. There's a poem which I often quote by John Donne, which says, "No man is an island." In other words, everybody is linked together. And therefore, the way we treat elderly people actually impacts on the rest of us. So I think we should really push back against those kind of thinking. We have a duty to do the best for everybody. And I think it's really actually wonderful how, certainly in the UK, there's been this whole focus on trying to protect older people. A great deal of concern about elderly care homes, about trying to ensure that people in these care homes get the very best possible care. And that, I think, is a fundamental Christian ethical principle.
It's interesting to see how much the Christian ethical principles come out at a time of crisis like this, even though many of us live in societies now which don't subscribe to them. The next question, and you've touched on this already, John, but if PPE, personal protective equipment, is inadequate, or perhaps even if the very best PPE is not available, should we as Christian health professionals refuse to see a COVID-19 patient or suspect?
Yeah, thanks. I mean, this is an exquisitely painful and difficult situation. And to be honest, I feel rather bad. Here I am, a retired doctor, sitting on my backside in perfect safety in my home, telling people on the front line who may be risking their lives how to behave. And so, I don't feel anybody has the right to tell someone else how to behave in this kind of desperate situation. In the end, each one of us, as I said, we're answerable to God for the decisions we make. But I do feel that, healthcare and being a doctor for most of times of history has always been a dangerous occupation. It's always means exposing ourselves to risk. And perhaps, many medics had got the impression just in the last few decades that actually medicine was just a profession like anyone else. It was just a nice, well-paid, secure, high-status job. And what we're learning is what medics have known for 2,000 years, is that if we commit ourselves to care for others, that means we are exposing ourselves to risk. Yes, we have a duty to try to minimize the risk, but I feel unhappy about this total focus on I must protect myself. I refuse to go to work if I cannot be guaranteed absolutely 100% protective equipment. So I do feel if we look into history and see the way that Christian carers have often responded in times of pandemic, we see that there is a time where we're prepared to risk our own lives in order to show the love of Christ to others.
Thanks. Here's another popular question to do with stopping treatment that's already been started. Does a doctor have the right to stop the vital support of a patient with very low chances of survival? And in what circumstances would we decide to take that course of action?
Yes, thanks. Very important question. And the short answer is yes, I believe we do. Just because a treatment has been started doesn't mean that we don't have the right to stop it. And therefore, I think at every moment we have to do this balancing. We have to be balancing the benefits against the risks. So if it becomes obvious that this patient is unlikely to benefit, and as I've said, the statistics are now coming out that in some intensive care units, more than 50% of patients who've been ventilated for COVID-19 have died, and many of them have gone on for 2, 3, 4 weeks. So I do think that there is definitely, and particularly in situations where resources are being overwhelmed, there is an argument to saying if it's clear that this patient the chances of them getting better is now extremely small, then there is a right to stop it. But it's important to understand that the reason for stopping the treatment is primarily for the good of that patient. It's not that we're doing this so that we can get another patient into the ITU. What we're doing is we're saying it's better that actually we're causing harm by going on and on and on with intensive care. And so for the good of the patient, there comes a time when we should say enough is enough. Now, I know as a clinician, that is a very hard decision to take. It's much easier. The default position is always, let's carry on the intensive care for another day. Let's carry on and see what happens. And to have the courage to say, enough is enough. We've come to the point where we have to stop this treatment. That's very difficult for clinicians. Sometimes we need to do it as a joint decision and have an informal committee or something like that. But I do think we should have the courage to be able to say enough is enough.
Thanks very much. A lot of what you've spoken about is the care of the patient in front of you. I've got a question here about the next step back. Those of us who've got administrative responsibilities, and in particular making decisions about how scarce resources should be allocated between different units as well. So are there any biblical principles that could help us decide, for example, about which hospitals should get the supply of ventilators when that supply is limited? And the person who's asking is saying they're in a position to give opinions and distributing ventilators to about 55 hospitals that have applied for ventilator donation. So, this is from an Indonesian context where there are COVID-19 referral hospitals specifically set up. There are other non-COVID hospitals in rural areas. There are some hospitals which are specialist hospitals or in urban areas. So, any thoughts about the best kind of way of approaching it from a Christian perspective of someone in that position?
Thanks very much. That's really interesting, difficult questions there. And I have to say, I'm not a public health specialist, and I would think that some of these decisions are particularly the issues that public health specialists grapple with. I think from a Christian point of view, again, the basic principle is that we should be using these valuable resources in a way which is going to bring the maximum benefit. And so I think it probably is a good principle of trying to isolate the COVID-19 patients into specialist centres. And then certainly that's what's happening in the UK. We're nominating certain hospitals as COVID-19 hospitals, and then they're nominating other hospitals as COVID-free hospitals. And therefore they're routing patients who've tested negative or who have other health conditions. So I would think principles like that is as a way of trying to maximize effectiveness, certainly is important. However, I think we should be careful from a Christian point of view. There's always the possibility of various kinds of coercion or corruption, isn't there? People who are prepared to pay more, people who have political power. And I think it's really important as Christians we stand back against that and we say that every life is valuable and we don't allow ourselves to be coerced or corrupted by money or by political power. Again, easier said than done for me sitting here in London, but I know that in many countries these issues are really complex and difficult. But there is a time where we need to stand up and say this is what's just, this is what's fair. There's just one other thing I want to say, and that is there's a lot of evidence coming out now that if we focus too much attention on COVID, that there are deaths increase from other conditions. We're seeing a lot of this in the UK. We're seeing children dying from acute sepsis, meningitis, and we're seeing older people not attending because of a heart attack or because of stroke. So because there's so much attention on COVID, it may be that other killer diseases may expand. I know there's a lot of concern about malaria in certain low resource countries in Africa and elsewhere. So I think, again, when we're involved in public health, we mustn't become too overwhelmed by one condition. We must try to see the whole picture and act as wisely and as justly as possible.
Thank you. This next question, John, preempts another talk that we hope you're going to be giving on the webinar series later. So don't feel obliged to go into it in great depth, but you can perhaps give a taster. And the question is this: what can we learn from church history when it comes to thinking about pandemics?
Yeah, well, thanks very much. And so I am planning to give another webinar because it's a topic I've been really particularly interested in. And the short answer is we can learn a lot from church history. This is not a new situation. Christians have been facing this right from the days of the early church. And what's more, some church historians think that the ways that Christians responded in pandemic was one of the most vital ways, one of the most important ways, which led to the explosive growth of the early church in the first 3 centuries. So it could be really important. God can use these times of emergency as a means of getting through to people who are holding him at arm's length. And so we have to be prepared to take the opportunities, but those opportunities may involve sacrifice.
A question on vaccines. One of the ways out of this, obviously, is for effective vaccines to be developed. And one can wait until people develop the disease, or one can actually give the disease to, or expose people to the disease. So this is the question, this potential shortcut involving purposefully exposing volunteers to the virus. What do you think about this approach? Is it ethical, given that it could mean that a vaccine would be available much, much earlier? So it's touching on this utilitarian question, I guess. But we use volunteers for a lot of medical trials, don't we? What are your thoughts on this?
Well, that's really interesting. I think the critical thing, of course, is the difference between when we're talking about medical research and when we're talking about standard medical treatment, because they're not the same things. Standard medical treatment, I think we all agree, we should only use treatments for which there is strong evidence, and strong evidence that the benefits are greater than the risks. So I would not be at all in favor of trying out some kind of experimental treatments without regarding it as research. And the important principle about research is that we have to get informed consent. We have to tell people that what we are proposing to do is not standard medical treatment. It's an experiment, and we don't know whether it will work. And what's more, it might damage you. In fact, if we're deliberately infecting people with COVID, we might kill them. And if you were going to do it, you'd have to make sure, one, that you had ethical committee approval of whatever in your hospital, in your country, what kind of ethical approval mechanism there was, but also you'd have to make sure that there was informed consent, that you were making sure that everybody who agreed really understood what they were doing and understood the risks. But there is definitely a case for doing even risky research, provided that volunteers are not coerced and they are properly informed. And the history of medicine shows that sometimes very risky research has led to extremely valuable methods. So I certainly feel there's a real place for doing research and for trying out experimental treatments, but we must follow good ethical principles.
Yes, and I guess this is a situation where risk can be assessed, because we would hope the volunteers that would come forward would be people who, if they contracted COVID-19, would have a very, very, very low risk of actually being adversely affected by it. We've got another question on risk here, John. If a doctor works in a hospital where he or she is not provided with PPE, is it ethical to resign in order to protect their own and perhaps even more importantly their family's health when there might be vulnerable people in the family?
Yeah, well, thanks. And again, I think this is just a desperately painful decision, and I don't think it's for me to tell somebody who's facing this kind of desperate dilemma what to do. And I can imagine myself, if I put myself in that situation, say I have a wife and young kids at home, or maybe I have an elderly relative at home, and I'm thinking, should I put myself at should I put them at risk because of my job? Of course, there is the possibility, and it's happening quite a lot here in the UK, and that is that people say, well, I will go and work in the COVID hospital, but I'll separate from my family temporarily in order to protect them. And that is happening quite a lot. People are choosing to live in dormitory accommodation or whatever, and they're doing it out of their concern to care for the patients. So I think sometimes we just need to be creative. We need to look for solutions rather than just see a binary choice. I either do X or I do Y, and they both seem terrible choices. Very often what Christian ethics has to do is to say, let's be creative, let's be innovative. Could we invent a better solution which on the one hand minimizes the risk, but at the same time helps us to practice compassionately and to use our vocation as healthcare professionals. So often we shouldn't allow ourselves to be just driven into these binary choices. Instead, we need to be creative, we need to be innovative, and actually we need to pray that the Spirit would give us and help us to be innovative and creative.
Yes, and I guess PPE is an area where there's huge innovation and creativity possible if we're prepared to accept that we might not be able to have exactly the best PPE available anywhere in the world. There are many ways of mobilizing people to produce stuff that's almost as good.
Yes.
Another question.
Just interestingly, somebody just told me yesterday that the underlay, the felt that is used in roofs, in insulation, actually has very particular microbiological properties, which are very similar to what PPE is made out of. So I can just imagine people walking around with underlay from roofing, and trying to create material using that. So who knows?
Yeah, some great videos out there. Next question. Someone from a resource poor country who was saying that a very important person in their health service, after they complained about their presence in hospitals during the pandemic, said that being on the front line is your job as future doctors, even if you're a medical student. How should medical students react when faced with that kind of, should we say, advice or recommendation?
Well, I'm afraid that, the model of leadership, which we find in the Lord Jesus, is servant leadership, isn't it? In other words, Jesus as the leader is prepared to sacrifice himself for good of the people. So I don't have a lot of time for politicians or very important people who instruct others to put themselves at risk while they're protecting themselves. But seriously, I do think, it's happening here that quite a lot of final year medical students are being accelerated through and are starting to work in COVID hospitals. And inevitably they feel very much out of their depth and they're not going to be able to function at the same level. But I think there is a place, again, for taking medical students who've done a reasonable amount of the training and with the right kind of supervision and support, encouraging them to work. But again, if we're doing that, we have a duty to try and protect them from harm as much as possible.
Thank you very much. Well, I'm afraid that's probably just about all we've got time for today. So just in closing, John, can I thank you once again for your time, for all your preparation and insight and wisdom into this very challenging topic, and for answering the questions so well. And we look forward to having you back on the program later to talking about what Christians can learn about the history of Christianity with respect to pandemics. So thank you very much. Visit the website, tell others, sign up for coming seminars, and thank you very much for attending.
Thanks very much indeed. Goodbye, everybody.